And when he goes to the tertiary care hospital, they will ask you as physicians, when he comes here for the chest pain, why didn't you do ECG? So in that way, you cannot defend yourself. Safety netting give you a provision that in these scenarios or any scenarios, you need to do safety netting. What is the safety netting? Safety netting, you say that, okay, the patient has chest pain, so he does not have sweating, he does not have heaviness, he does not have any risk factors. So these are safety nettings. His ECG was normal. So on these bases, I presume that this chest pain is not because of cardiac problem, but it is because of musculoskeletal problem. So now when I saw the patient, I knew that, okay, at that time in the primary healthcare when he was presented, it wasn't like that. Here it is different. So why am as a secondary consultant, I reached to that diagnosis because there is a good safety netting. So whenever you disconnect with the patient or terminate your consultation, make sure that you do these safety netting features. Housekeeping. Am I in good enough shape for the next patient? You also need to think on your part that if I saw 10 patients, obviously the 11th patient is going to come. The first patient that I saw and that 11th patient that I'm seeing, we have different energies. So you also need to see that if you think that you're not going to make it very ideally, then you probably would like to take some rest. Yes.
Is the safety netting is not like in each consultation? For example, the patient is coming each time with chest pain. So each time do example ECG or something like that?
No. Each time you do safety netting, and that safety netting does not necessarily include ECG. When we discuss about chest pain, there are some things that is called typical chest pain. There are some features, clinical features, and there are some clinical features which suggest that the chest pain is not because of cardiac. So there are 3 cardinal points in that. If you mention these cardinal points, that based on this, I assume that this chest pain is musculoskeletal, and these are evidence based. So maybe the clinical points or examination findings can be a safety netting point, not just necessarily an investigation.
Yes, but like for example, if the patient came for me twice, and each time I took the DL history, and
Yeah.
he was okay.
Uh-huh.
I think, for example, chest pain.
Mm-hmm.
But like I keep doing it each time, right?
Yes, the analysis you need to do each time, every time, yes.
Even if he came to me multiple times and he was okay.
And he was okay, yes, because there are some important things that you need to ask. There won't be very extensive things. Usually the differentiating points when you go into your consultation, you will find out that only 2-3 questions will give me the idea that whether this patient is having the true problem or is not true problem. So you don't have to go into much of details every time, because as you get experience in your consultation, you will find out that there are some specific clinical points that I need to pick up, maybe 2-3 points in every long presenting complaints. This will give you an idea. You don't need to go into the extensive details later on when you go into your professional career. So it does not necessarily have to have a very extensive consultations. Okay. Now, safe, efficient, effective healthcare, understanding the patient's problem, improving the communication leads to better patient outcomes. So these are all outcomes. Why do you want to do effective consultation? Barriers. Now talk about barriers. There are doctor-related barriers, patient-related barriers, place-related barriers, system-related barriers. So you need to be aware that what is the problem. First is, you first need to identify, is there any problem or no problem. If there is a problem means if there is an uncomfortable feeling between me and my patient. If I am not comfortable talking to the patient. If patient you think that is not comfortable, then you need to think in the way, why? Am I being very rude? or the patient is being very, sometimes you take patient's history and is being examined and history taken in the first half, and then you're going into the second half again to the patient, and the patient is very fatigued. So always the patient factor that does not allow you a very good consultation. Sometimes you as doctor is very tired, hurried up, and then you want to just wrap up the patient's problem. You do not want to listen to long conversations and things like that. So that's your problem. So once you get to the reach that what is the problem, then only then you can identify or fix that issue. Place. You do not have enough place, no privacy. People are coming back. So maybe there is a place issue that the patient is not opening up with some confidential problems. There are females' confidential problems, males' confidential problems, and you are sitting in a public clinic where there are 5 doctors are sitting in the same consultation room and seeing 5 patients at the same time. So that's maybe because of the place that you have barriers. Because sometimes because of the system, you can manage this newly diagnosed diabetes, but you have to refer the patient because the system says that a newly diagnosed patient you are not going to treat. You had to take the opinion from the endocrinologist. You have the clear-cut diagnosis. Every diabetic patient, you don't need to refer it. It's your patient, you can deal it. But according to the departmental policy or to the institutional policy, you had to take opinions from the others. So system can create these kind of sometimes systems can create these kind of uncomfortable consultations between you and your patient. So identify these barriers also. So essential skills for the effective consultation are 2. There are 2 circles in it. One is verbal, where they do presenting complaint, history of presenting complaint, maybe some psychological things, some non-psychological things, some rapport buildings, safety nettings, all that which comes into the verbal thing. And there are some non-verbal clues. When the patient is talking to me, I'm writing up the prescription. I'm talking on the phone, maybe writing out some messages. So this is a non-verbal communication that, okay, the doctor is not really concerned with me. Or you can see the non-verbal communication from the patient, that the patient is in hurry up and he just want to finish things up and he's very exhausted. So with the body language, you also need to consider what is the body language what is your body language as a physician and what is the patient's body language as a patient. The consultations in the age group. If you're interacting with a child, obviously you need to develop some kind of very friendly, very joyful, very playful kind of a consultation if you're dealing with children. And obviously if you're dealing with adults or elderly patients, you can be very respectful. You can be very maybe loud sometimes because elderlies, they listen to loud things. You may be very slow because they understand very slowly. Adults, which kind of age group you are dealing with, females, which kind of age group you are dealing with, you need to modulate or modify your consultation. Handicapped patients is one special thing. Mental instability, you identify that the patient has some mental problems. So you may want to do your consultation in a very brief, straightforward kind of a manner. Maybe you are dealing with angry patients. So if the patient is angry, you need to save yourself. You need to be very concise. You need to quickly come to the agenda of the patient. You do not want the patient to get into much of the administrative thing. And the bad news. These are all situations which makes the consultation modifiable in different situations. So that's about consultation models. And the take-home message with these consultation model is, when you started to have your own patients, these are all consultation models that they're there. You're not required to actually remember the names, but you are required to take the take-home message from them and create your own consultation style which is effective to the patient. How is going to be effective? If you think that I'm satisfied with the consultation that I've done, you will realize that this my consultation is effective or not very effective. So if it is not very effective, then you need to analyze the problems. What is the problem? Is it because of my communication? Is it because of the patient's communication? Or is it because of the environment? Rectify these, identify it, solve it, and then do it, give it another shot. And maybe you can, this consultations, by the way, is changing with your experiences, with the time settings, and with the patients that you are treating. Your community can change your practice. So create your own style, have a look of these things, and try to make your own special, unique consultation. All right? Okay, thank you.